Afro-Caribbean, 1 out of 2, that's 50%.
No, just two individuals. So statistically, it's 0.
That's 50%.
Yeah.
3 out of 9 in the Middle East, that's 33%.
Yeah.
That's quite common in both cases. And I thought I wouldn't see a rickets in Iraq until a few years ago on one of my visits. Our house became a clinic in the night, and our father brought 2 kids. Honestly, with severe undiagnosed rickets. And the recommendation of the nutrition to send them outside to have physiotherapy is obviously rickets. Nobody checked on that. My question to you, why is it common among the Afro-Caribbeans and the Middle East women, pregnant women or children to have low calcium? Is it their diet, lack of milk or less milk in their diet? Or the color of their skin, we're talking about the pigments, the melanin and the absorption, making the vitamin D, or it is lack of exposure to the sunlight?
Well, that's a very pertinent question. My answer to it is that if you take people from the Asian community, they tend to overcover themselves. They don't go out in the sun. Some of them, not the majority, by the way, the majority of ladies who cover themselves, they eat well, they expose themselves in the garden nicely. So take that aside. I'm talking about those who overcover and don't go out, and their nutrition might be also a question mark about it. That's why it was so common in the Asians. It was 3 out of 9 ladies of Middle Eastern origin, which will be compatible with the diagnosis, with the numbers I gave, with the description I gave. Afro-Caribbeans, I was actually expecting nobody to be, because they are always out and the dress code is completely different. I suppose some of it is nutritional. But when it comes to African and Asian and Middle Eastern, my suspicion is one is the exposure to sunlight, 2, nutrition. And they go together. I don't know, did I answer you?
You're correct of yours, but we know the darker the color,
absolutely,
the less they go to vitamin D. And there are different studies in America about prognosis, cancer prognosis related to vitamin D deficiency. And clearly there is a huge difference in the mortality between the North America and the South, because the North has less sun than the South. But various studies are with conflicting results, so we don't know what it seems it does. And I think COVID studies have brought vitamin D back to their life. People talking about vitamin D and the importance of vitamin D to their immunity.
Okay,
lovely.
All right.
Thank you
very much. So, for the interest of time, we need to move on, but thank you again. If you could, I think we just need to get your presentation up, don't we? Which one is yours?
It's human factors.
Human factors.
Yes.
Right. You just click on as well, yeah. You can use this or the mouse or the buttons there.
Yeah.
So moving on to the next session. So I'm delighted to have Dr. Munawar AlMudhafar, who has graduated from the College of Medicine, University of Baghdad, completed his training at the Medical City Hospitals in Baghdad. He holds a fellowship at the Royal College of Surgeons in Ireland. He further trained in emergency medicine at Oxford Medical Deanery and obtained a fellowship from the Royal College of Emergency Physicians in Britain. He's also earned a medical education certificate from Cardiff University. And Dr. Mulafar is currently a consultant physician in emergency medicine. I'm sure I've met you at some point in the Heath, so I apologise for
I was just talking to someone who said, I visited A&E a few years ago, and I said, the cognitive load, the number of patients we see, I probably won't remember anyone who I've seen 2-3 years ago, 450 patients plus, so it's very hard, but I'm sure, I mean, face is familiar.
And he's also a lecturer at the College of Medicine in Cardiff University. So welcome Dr. Munawar, and he's going to be talking about human factors training for healthcare professionals.
Okay, thank you very much for inviting me. Thanks, Dr. Amr. And it's very hard for me to entertain you now after Dr. Al-Faham lectures. I could have talked to you about things we do in A&Es, saving lives, sometimes from opening chests on the spots to resuscitations to very sad cases, suicide in children, can be very traumatizing. But in any meeting or conference, there is this one talk that is not medical, and sometimes it has to be delivered. So I thought I'll choose a topic that is non-medical to talk about. And adding to your misery, probably some of you are wanting to know the result of the football between Iraq and Argentina while listening to me, but I hope I'll be able to get some messages to you now. The reason why I'm talking about human factors in healthcare, and it's only an interest that I developed lately, because in addition to my job, so just put the timer here. In addition to my job as a consultant in emergency medicine, I'm also a faculty lead in the medical education department in Cardiff and Vale University Health Board. And for those who work in Wales, they probably know what is HEIW, which is Health Education Improvement Wales, similar to deaneries in England. And the role I do is that I'm appointed by HEIW, so one of 4 faculty leads in the health board, to basically supervise postgraduate and undergraduate training in the hospital. So we deal with concerns. We have very busy time. Actually, this time when the GMC surveys are out, and then we go and investigate what went wrong with one department, what other departments did well, and advise them then to share good practices with. So this is one activity that we do. In addition to that, we run a few courses, and one of them is a human factors course in healthcare. So human factors in Arabic, I think it's al-awamil al-bashariyya. Just the mouse. Yeah. Okay. So the first slide has to be about the definition of a human factors. So what are human factors? So basically, these are behaviors not directly related to the use of medical expertise, drugs, or equipments. They encompass both interpersonal skills like communication skills, teamworking, leadership, and also cognitive skills like situational awareness, decision making, and conflict resolutions. So the diagram shows, these skills, the human factor skills, which are essentially, in other terms, what's called also non-technical skills. So we as healthcare professionals, we do have technical skills. We are well trained in performing a procedure, but in addition to that, we should have some of these non-technical skills to allow us to practice safely in our settings. But the difference between human factors skills and non-technical skills is that basically human factor skills are more than just non-technical skills. The non-technical skills are literally decision-making, situational awareness, communication skill. But the human factors, although closely related to the non-technical skills, but it's much wider. It's about the interaction with the system, with the setting we are working with. And that's why very often it's often referred to as ergonomics or بيئة العمل. is basically, yeah, that's another term equivalent to human factors. So why are they important, these human factors? There are many reasons, but the top two reasons are because the human factors and patient safety are highly linked. And I'll come and talk about this a little bit more. And also, it's featuring more and more in postgraduate curricula. So, going back to the first reason why human factors are important, it's found that, and unfortunately, and that's the reality, and these statistics are from NHS hospitals, that there are, despite our best efforts, that there are still unnecessarily deaths and adverse events, significant events that happen every year in the NHS, in the thousands. These can be examples, just operating on a wrong knee, can be administering an antibiotic to a patient who is allergic to. It can be as simple as that. And it's not that because I'm a surgeon who doesn't know how to operate on the knee. I do know how, but it's just unfortunately did the arthroscopy on the other knee because of lack of attention of other factors, etc., etc. So every one of us, makes errors, no matter how well trained and motivated. But sometimes we are set up by the system to fail. And the challenge for us as physicians is obviously to stay up to date, excel, be competent in procedures, but also to develop an error-tolerant systems and to prevent errors from keeping occurring. So how understanding human factors help us to build better defenses in these systems? So the value of the human factors is basically in that it allows us to understand how humans make errors, how we can improve our safety culture within teams and the organization, how to enhance teamwork and communication, identify what went wrong, and helping us to predict what could go wrong in the future, and then improving the design of the system and processes we work in. So that's really the value of human factors. And so I repeatedly said, most of us competent in what we do, and therefore, actually, most errors, when they happen, it's about 60 to 70% of them are due to human errors, communications, inability to work within teams, inability to take or make effective decision making, lack of situational awareness, as opposed to us not being technically competent. The Canadians aviation authorities came up with this list, and it's a very well-known concept in the science of human factors, and they call them the human factors dirty dozens. So 12 human factors that can contribute to errors in a workplace. And these actually, if you read through all of them, they are all applicable to our own settings in healthcare. Talking about errors, human factors, and why errors happens, you will always find the concept of Swiss cheese model. And for those of you who are experienced and hold management positions, they know or they've heard about the Swiss cheese model. And basically, in this model, which was described in 1990 by a scientist from Manchester called Reason. And it's a very respected model in knowing why errors happen. So in every system, there are what we call them barriers or defense barriers that will stop, hopefully, errors from happening. But when these holes, or what they call them latent errors, and these barriers are aligned in one line, this is when it contributes to the error. So I may go to my shift feeling, hungry, I'm late, I'm tired. It may not be enough for the error to happen, but then on the top of that, we are short-staffed. My colleague or SHO hasn't shown up to work, and then an equipment has failed, or computers collapse. So eventually, when all these, gets connected, an error is likely to happen, and as it's shown here by the straight line. Other errors are, though, due to very obvious active failures when we are really unsafe in our practice. But the majority of errors are due to the Swiss cheese models, due to multiple of factors. I'm sorry if the slide is busy, but I deliberately made it like this in case someone wants the presentations. So interest in human factors in healthcare started with a very, very famous case called Elaine Bromley case. Probably surgeons, anesthetists, most of them heard of this case. So Mrs. Bromley was a 37-year-old, fit and healthy mother of two, who in 2005 underwent a routine sinus operation, which was meant to be a simple procedure. During intubation, the anesthetist encountered difficulties with intubating the patient and preparing her for the operation. They reached a stage where it's well known by the anesthetists called can't intubate, can't ventilate situation. So one anesthetist couldn't intubate, asked another consultant colleague to come and try, who couldn't. Then another consultant colleague came and tried and couldn't intubate the patient. So the consultants wasted long time trying to intubate this patient, despite there's a clear guidance at the time is what to do when you are faced with this situation. They should have resorted to different pieces of equipment, for example, abandon endotracheal intubation and put what's called laryngeal mask airway. So there are different options that they didn't follow. Interestingly, nurses who are, traditionally they are really well taught and they recognize the situation. They brought these equipments to the anesthetist, and they left the equipment next to them without telling the consultants that these are for you to use, because they feared, that they will be told off just by interfering with the job of these consultants. And the situation continued until these consultants decided enough is enough, let's wake up the patient. Sadly, the patient did not wake up from sleep, went to ITU and died after 13 days. So what's happened, and this is also a lesson to all of us, and probably this case happened many, many times before in different hospitals, different countries, but the husband of this patient was a pilot. And in the pilot industry, human factors training is very, very important. And they had so much training about this checklists that they implement or they use in their day-to-day practice. And he, as a pilot with his common sense, realized that, following the inquest report, that there are so many things, that could have been followed up and changed the course of the case of his wife. So the video, so he established then a group called the Clinical Human Factors Group, very well respected group, and they showed videos about human factors, including the video about the case of his wife. So from 2005 then, there was this interest in embedding human factors training in healthcare settings. Just talking about a few learning points from the Elaine Bromley case, because this illustrates the importance of the human factors. So the three learning points from from the case, and the investigation showed what went wrong, is that there was a loss of what's called situational awareness. Is that because the situation was so stressful, those experienced consultants just focused on the task. And this is a very common error. It's called, in human factor science, fixation error. And there are three types of this fixation error. There is this and only this error, which is our cognitive tunnel vision error, as illustrated in this case. They focused only on this task and ignored everything else. Example of that, when we have a patient with major trauma in the emergency department, the patients might present with deformed ankle. That is very obvious to everyone. But at the same time, they have a hidden pelvic fracture bone. And an inexperienced person might be very tempted just to go straight to the ankle and try to manipulate it, straighten it, but this may cause more damage to the pelvis fracture. So just focusing on one thing, it's called fixation error, and that's a common error we do in our practice. There is another type of fixation error called everything is okay error. And this happens when someone who doesn't like moving from a routine situation to an emergency one, they are very slow to react. For example, you have a patient with sepsis who are becoming hypotensive, but the healthcare staff is attributing that to a problem with the cuff and the monitor rather than with the evolving sepsis. So they tend to ignore things till a later stage. And then there is the other type of error called everything but this error. Is another common type of fixation error. For example, when a patient is intubated, but they remain hypoxic, and the anesthetists believe that he still intubated the trachea, but the tube is in the esophagus. He thinks that the resultant bronchospasm, the hypoxia, is due to aspiration, not to his incompetency, for example. So in this case, there was clear loss of situational awareness by the physicians there. There was a poor decision making. I apologize, it's not masking, so it's making. And we teach in our workshops, and we do play games, in the decision making workshop. We always try to emphasize that there are always other options. Don't stick to one option. In fact, the definition of decision making is basically choosing between options. So don't restrict yourself to one option only. And in this case, they done that sadly. And then the third error that's happened in Elaine Bromley case was the lack of effective teamwork. Although there were 3 consultants in the operating theater, none of them was an obvious leader. They did not communicate well with the nursing staff, despite the nursing staff brought the trolley with other equipments. The nurses, because of fear or lack of assertiveness, for example, they did not tell the consultants about this. Yeah. So they didn't tell them about this, and sadly this what's happened. So back again to this slide is why they are important. So human factors are important because they are linked to patient safety. Most of the errors happen, in fact, due to misunderstanding of these human factors as opposed to the technical problems. And I always put in them during my presentation a slide, just make it interactive. Does anyone know what is this?
Mobile phone.
Yeah. So it's a file, yeah, but it's high visibility file. So what's happened now in some communities when district nurses visit patients at home, yeah, in order to not to forget the folder in the car, which happened many times before, and you hear horror stories, not just us, but even politicians forgetting their laptops, and yeah. So they decided make it highly visible so that when you lock the car, just look quickly, yeah, it's there, yeah. So there are simple things. You don't have to even do courses or use high-tech things. There are simple human factors aspects that can change the course of a patient's journey. So we said the first reason is about patient safety and errors. The second reason why human factors are becoming more important is they are becoming part of postgraduate training. Our trainees are being assessed on these skills. For example, in the emergency medicine curriculum, we have a workplace-based assessment called ASLE, which is an extended supervised learning event, where we assess the trainees' situational awareness skill, decision-making skill, communication skills, task management skills, conflict resolutions. So they are becoming part of these curriculum, and they can't progress to the next stage of training without mastering these. There are now some good resources available. In particular, the Royal College of Surgeons of Edinburgh have really good course about these non-technical skills and the importance of human factors. Their manual is available free on their website. They have very nice videos on their website to demonstrate all of these skills. And because of this important aspect, these are being featured more and more in the postgraduate curricula. We took it on ourselves as a medical education department and the health board to run courses to improve the human training skills. And this is a poster that we presented recently in one of HIW conferences about the course we run. So you can tell even, trainees at different levels of training, only 12% of them were aware of the concept of a human factors course. After the course, this jumped to 80%. Some believe that the course is going to change their practice as a result of what they've learned. So it is becoming more and more important. And the final slide is just, I thought I will use ChatGPT and ask to write a poem about the human factors. And this is what it comes with. A very long poem, but I only chose the last few lines from it. I'm not sure if it's very good English, but it seems it illustrates the importance of these human factors. Questions, please? Thank you. Thank you.
Thank you so much. That was an excellent talk. I've read a book called Black Box Theory. I don't know if you've read it, but there's a guy called Matthew Said, and he opens his book with that story about Elaine.
Yeah.
And one of the two things that he highlighted, the difference between the aerospace industry and the healthcare industry. Obviously, the risks are different because you go onto a plane and you expect to go onto the other side safely. Yeah. Well, healthcare is very risky.
Yes.
That one of the two problems that we have in healthcare is that the medical profession is almost seen as it has to be perfect, infallible, and that there still is a blame culture within there, and that stops people from, the nurse who was in the theatre not pushing herself and saying, "Here's the tracheostomy kit, do it."
Yeah.
So I don't know, but any questions?
Thank you so much for that talk.
You are welcome.
Very, very relevant. Not talk boring, actually. It's very relevant, especially to surgeons. I've done the NOTS course with Sarah Hemley-Gorse and the team in the HIW. And yes, surgeons are the most tunnel vision people that exist. So very relevant to us. And I understand you take it as part of the emergency medicine curriculum. Do you think it's something that should be integrated even earlier, for example, medical nursing school?
Yeah, I firmly believe in that. And actually, we do see more and more medical students doing their clinical placements at early stages, and they are exposed, to the real life of a doctor. So, so definitely there is a room for this, and I'm sure, the GMC will look into that and will ask the medical schools to change their curriculum maybe in 5 years' time and try to incorporate these into the undergraduate curriculum. Yeah.
What's your thoughts on integrating into simulation training?
Very good. Yeah, definitely. Yeah, simulation. There is good evidence that simulation improves these human factors. There have been lots in the literature about this, and it does a good job. Yeah.
We've got time for one more question.
Yeah, thanks.
Thank you, Munawar, for very interesting. Being anaesthetist and the correlation between anaesthetist and a pilot is actually anesthesia is dangerous at the time of induction and at the time of
waking up.
The same thing as a pilot is with takeoff and landing. These are the most dangerous time, really. And the thing is that you said about the involving teamwork.
Yes.
I think it's very important that when we do the briefing before we establish the operation, even we involve the porter. And for example, about the intubation, we said that no trace, wrong place. So if you don't have the carbon dioxide tracing, and sometimes even the porter will tell you that.
Yes.
So when the porter said, "Doctor, I can't see that." So something went wrong, and which is very important, really. I mean, the problem is that this is business of the hierarchy. No, I don't want really somebody to tell me what. No, I think that we need to change the culture.
Exactly. I mean, sometimes it's important to have this assertiveness, like, when you see something wrong in front of you as a team leader, you enforce it. But, I mean, we should lower this hierarchy as well. I mean, we have it in our practice. For example, when we manage trauma patients, major trauma patients, we have a person who we call them scribe. Their role is just to write what's happening, and then they very often ask us to say something because they haven't heard it, or even remind us of something, and we accept it from them, and we do a lot of debrief sessions after each interesting case, for example, significant trauma case, and we discuss these things, and it's very useful.
Excellent. Okay, I think we need to move on.
Thank you.
I think we'll have dinner following all the lectures, so if there will be an opportunity to ask further questions during the dinner. Thank you, Dr. Munawar.
Okay.
Excellent.
Thank you.
So if I can just welcome Dr. Yusuf Jafar, who I've known for a very, very long time as a childhood friend. So it's a pleasure to introduce her. She is a consultant breast and gynecology radiologist. She obtained her undergraduate MBCH-B from Cardiff University in 2011. Went on to do Part A of the MRCS from the Royal College of Surgeons of Edinburgh in 2014, and then went on to fellowship exams, which she passed in 2018. She currently works in Tawam Hospital in the United Arab Emirates, having previously served as a consultant at Nottingham University Hospital's NHS Trust. She's completed a breast radiology fellowship at the National Breast Imaging Academy and has participated in numerous courses and conferences. Her accolades include the, I'm not sure what these stand for, but SRT BSBR Poster Prize and a nomination for the Best Trainee Award for Radiology in Wales. So she's going to be talking about her jump to the Middle East, to the United Arab Emirates, and thank you for joining us.
20 minutes.
20 minutes, yeah.
No problem. Probably it'll be quicker, I promise. Okay, thank you very much for the introduction, and I'm delighted to be here today to speak to you all about my experience in the United Arab Emirates. So I recently moved to the UAE 7 months ago, so in January of this year. I made the decision to leave the NHS and go on a new adventure. And I know many of you will be asking me why I've done that, and I will explain.
Well done.
Thank you. Okay, so I graduated from Cardiff University Medical School in 2011. I then completed my foundation training in the Wales Deanery. After that, I went to Liverpool for a year of core surgical training and did my MRCS, and then I went into radiology training back in Cardiff in 2014. During my 5.5 years, I trained in breast and gynecology imaging as my chosen subspecialty. And I chose that subspecialty because I had a passion for women's health, and I knew that in the future that I would want to help women of my community in the Middle East when I get to the stage where I'm ready to do that. So I had that ambition 10 years ago, and I reached a point last year where I felt I was ready and confident enough to take on the world. So I just want to say to the younger women in the audience, I know Farah and Noor and the other girls, always have an ambition. The sky's the limit and the world is your oyster. So that's what the healthcare profession gives to you, and that's empowering as well. So I did, after my radiology training, I went to Nottingham, and that was to do a fellowship, and that was part of the National Breast Imaging Academy fellowship that was sort of started at that point. I was the first cohort, and that was a very competitive process where we had centralized interviews, and I managed to secure the most prestigious unit in the country, which is the Nottingham Breast Institute. And I did my fellowship. I started in February 2020. And unfortunately, 6 weeks into my fellowship, lockdown happened. So it cut my fellowship short to 6 months instead of 12. But in that time, I managed somehow to impress my colleagues there, and they wanted me to stay as a consultant. So I ended up staying as a consultant from August 2020 to January 24. So I've done 4 years. So I was a post-CCT fellow when I joined Nottingham, and then I did 3.5 years as a consultant before deciding to jump ship and go on an adventure and to achieve my career goals. So what do I do?
I think you can move
Just
with the mouse. The mouse.
Oh, like the scroll, that's it. Okay, so now this is where I work, in Tawam Hospital, which is in Al Ain, which is about an hour and a half from Abu Dhabi, an hour and 15 minutes from Dubai. And Tawam Al Ain is a very